I'm Andrea Barthwell, and I'm your moderator for today. And I'm really excited about this workshop. I was able to work with Dee to get these two fine ladies to my left, your right, here with us this afternoon. I'm going to introduce them, tell you a little bit about what we planned with this presentation, have some discussion amongst us that I want to invite you to join. And we're really looking at this piece this afternoon as a rest point to some of what's happened and as a prelude to what's going to happen yet, you know, what it was like, what's happened, what it's like now. And if you look at the descriptions, it really is sort of a evolutionary piece in that direction, because some of what we're struggling with is that we're in an environment that we don't completely understand because we don't completely know where it's going, and we've got to react to all of these external forces without having complete understanding of it. So this talk is to try to think a little bit about what's happened and what people have said already, to hear from them, to have some discussion here about how do we start to bring about and transform what it is that we do. And then I'm going to be summing up the whole conference on Wednesday. So if it doesn't make sense to you that I'm here as the moderator, it really is sort of a functional thing for me to be in the middle of this so that we get to the point. To put a little bit of context around the Access Conference too, I don't know about you, but for me, I've always left these conferences with an idea of something that I need to do. And I hope that you're having an experience of that, or at least coming to some recognition that things have to happen as a result of this. I would say that 3 or 4 years ago, I was talking to the people at the Sierra Tucson booth, and they had, if you know them, traditionally been some cash pay somewhat, and they told me that they'd made a transformation and they were getting about 60% of their revenue from insurance. And I heard that, and I went home to my team and I said, you know what, we better start looking at this. And at that point, we were completely cash pay. We now have transformed our base, where about 80% of our revenue comes from insurance out of network. And many of our admissions are admitted as PHP to discharge, with us being able to make the determination of what qualifies as discharge. So, I have a lot to thank the Access Conference for, because I might not have been making that move and thinking about things in that way had I not been here. And I hope that this conference serves you in that way also. Now, before we get started, I want to introduce you to the panelists. And again, I'm the moderator, and I'm here to make sure that I draw out of you the things that you want them to address. So we got to give you a little bit of background on them so that you'll know why they were selected and anointed for this particular panel. So to my far left is Eileen Parsons. She's a shareholder at Verploeg and Lumpkin, and they have offices in Miami and Orlando. She is an attorney professionally. She concentrates her practice on health care litigation, managed care litigation, health and life disability insurance, professional liability, and directors and officers insurance actions. Her clients include healthcare providers, physicians organizations, and medical and behavioral health facilities, primarily with respect to healthcare litigation and reimbursement disputes with third-party payers. Now, to give a little bit of disclosure, I worked as an expert witness for her on 2 cases, and one of the reasons that we wanted her here is that we have been waiting for a trial that she's been working on to go to trial so that we could get some case law in this area. We haven't quite gotten there because she always does such a good job that people want to settle and not go before a judge or a jury on her cases. Am I embarrassing you? No, it's true. It's all true. But I want her to talk with you today about some of that work, and then she's going to be available to us so that as you can think about the environment in which we're working and the things that Mike Barnes sort of foreshadowed in his talk from this morning about what might be going on in reimbursement, what you might be able to do to advocate for yourself. She routinely lectures on healthcare litigation, healthcare reform, managed care, behavioral health issues, health insurance, and other coverage matters, and ERISA and employee benefits. Now, the lady to my immediate left is Deni Carise. I always leave out one of the letters, Carise. Dr. Carise. She's a clinical psychologist and been part of the recovery community for over 28 years. She's the Chief Clinical Officer of Recovery Centers of America, a startup company whose goal is to get 1 million Americans into meaningful recovery, with an emphasis on recovery and not treatment. Dr. Carise was previously the Deputy CCO of CRC Health Group and CCO at Phoenix House, each company representing over 100 treatment programs. Prior to that, she has been with NIH, ONDCP, UNODC, and SAMHSA-funded researcher from 1993 to 2010, and her goal in her work has always been to find ways to enable others to achieve meaningful recovery from substance abuse and a better quality of life. She's worked extensively internationally. You see John down in the front. John is always talking to us about how our biggest export to the rest of the world is what we're doing in the treatment industry. She's helped recruit and train researchers across the globe, and she's also a frequent blogger on Huffington Post. Now, in this, the purpose of this workshop was to help us get a better understanding of our times so that you can begin to prepare for thinking about not just survival through the transformation, but growth or how to thrive in this environment. And in order to do that, you have to understand the threats and opportunities that these times pose. Now, in understanding what threats are out there, we have to understand where our soft spots are and sort of protect them. And we also have to understand and know what it is that we do and know what we do well, because those are the things that we're going to build on. You heard Dr. Waller last night talk about how a center of excellence would cover medical, hepatitis, treatment, outreach, community outreach, housing, and a variety of other areas. And most of us are not in a position to be able to do all of those things. And maybe if you were to follow his vision, we would create these mini centers of excellence starting in the addiction medicine area and building treatment around them. But you may have a history where you've been involved in the addiction treatment enterprise, as I call it, that has operated kind of outside of the healthcare system and as a safety net for the healthcare system. And you may be wanting to not create an addiction medicine center of excellence, but to bring more services either through collaboration or development within the addiction treatment enterprise so you can meet the needs of our patients in a more extensive way. So you are going to have to create a reality for yourself based upon your personal context and your understanding of this disease. And we're all going to have to grapple with some of the issues that he brought to the forefront, which has to do with the fact that from this endemic disorder, particularly opioid dependence, people are dying at rates that are much faster than we've been able to previously get to them. This is a point that John Southworth made to me at one point today after one of these lectures. You know, with marijuana use, there is a very slow trajectory of decline, and it takes about 35 years before the person takes a long look back and figures out that it has absolutely destroyed their life. Alcohol is about 20 years, and in that period of time between first use and first intervention, there was some time to catch them, to intervene upon them and get them to treatment. But between first use and death from opioids, it's a much shorter period. And people who typically try to intervene on these individuals and get them the help that they need are finding that they're not moving fast enough to catch them before they die. So how are we going to address the needs of that group that are bringing about tremendous shifts and changes in the ways in which addiction is viewed and responded to in this country. How are we going to address their needs when we have a system that's been prepared to wait 20 years or more before making its first intervention? And as a result of the sort of the crisis of between first use and death being so foreshortened, people are finding that they're tolerating, even advocating for things that had been distasteful in the past. So how does that environment begin to shape the way in which you and your service array that was developed at a time when you had 20 years to wait, how are you going to evolve? I'm going to stop there and let Ms. Parsons tell you a bit about the work that she's done on behalf of providers who want to get paid for the services that they've developed, and maybe talk a little bit about the tea leaves, what she's seeing coming down the pike. And then we're going to hear from Deni as she talks about how do you take what it is that you're doing and in a way that probably isn't going to break the bank, begin to evolve your services so that you can be more responsive in an environment where we don't have 20 years to wait before that first intervention. And then we'll have a conversation with you. So with that, I'm going to stop.
Thank you, Andrea. Can everybody hear me, I hope? And I do want to thank Andrea for asking me to be here, because it's I'm used to talking to a room full of lawyers usually, which it's a bit different here, but it gives me an opportunity to talk about what is a passion of mine. I've been lucky enough to practice law for 30 years, and some might say, isn't that long enough? And most days I say, isn't that long enough too? But then I get to practice still in this area, and I get to get up every morning and do something that I feel very passionately about, which I know that everybody in this room feels the same way, whichever side of the versus sign or whichever area that you are in providing access to healthcare, because that's what this is all about. We all here in this room want to ensure more access to better quality health care. In this arena, it's behavioral health, and that happens to be a passion. So yes, for the last 15, 16, 17 years or so, I've been fortunate enough to represent providers and individuals. My goal always to work with providers or individuals to ensure greater access to healthcare services, particularly behavioral health services. And because in the last 20 or 30 years or so, with the advent of commercial health insurance for behavioral health services, and as it has expanded, that has meant in large part figuring out how you get paid from not just government sources or self-pay, but how you get paid from commercials insurance, and particularly when it's primarily group health insurance. And so that's been my focus for the last 15, 16, 17 years. And when I look back on it and starting with it, it was usually just primarily about we're getting underpaid. We're not getting paid enough. So it was just more about under reimbursements, or that was what the focus seemed to be. Okay, how are we going to show the value of our services and make sure that we're getting paid appropriately for that? And there's a variety of different ways that I've worked with providers over the years in order to do that. But as I started to do that, the reason why the underpayments were so critical is really what nobody talks so much about, and really what nobody talks as much about in the industry, because I think people just think there's nothing really to be done about it, and it's not underpayment for care that is covered, medically necessary, authorized, approved, whatever you want to call it, but denied care, the lack of access to care in general, and how you all as providers of primarily addiction services or substance use disorder services, what do you do about a specialty which is amazing to me when you think about it, is one of the most underutilized, under-accessed specialty in medicine out there, yet at the same time, it's one of the most managed and controlled services out there. And the two just don't seem to make too much sense to me when I think about it. The overall medical expense cost for behavioral health services, when you look at the overall medical expense, it's still next to nothing, even with the advent of the ACA and parity laws. Yet it is still so controlled and so managed by a variety of sources, but let's call it what it is, primarily commercial health insurance. So what do you do about denied care? Because, I have providers who say to me, 10, 20, 30, 40 providers say to me sometimes on a daily basis in the atmosphere in which we're operating right now, well, what do? I either provide free care, or I follow their guidelines, or I do what the insurance companies have to say, or I go out of business, which is what their goal is. And there just seems to me there's got to be something else that we can do about that. So Andrea asked me to come here today, and I have to be honest with you, up until 5 minutes before we came on stage, she hadn't really told me what she wanted me to talk about here today, other than to send you the message that there are things that can be done. You do have a voice. There are mechanisms that you can use. It isn't all lost, and it's not right. And we need to do something to bring more access to behavioral health care services out there than there is now. I'm more than happy just to have a discussion with y'all and answer your questions about it, as opposed to me lecturing, about some of the things that we do. But I can talk about that as well, because people say, how do we challenge this? What do we do? The first thing that I can recommend you do, and please feel free to jump in, is, and don't take this the wrong way, don't shoot yourselves in the foot like you do every day. It's a challenging enough environment that you operate in. You are at such a disadvantage when it comes to being able to provide access and quality care and get paid for it. Don't shoot yourselves in the foot. Rule number 1, document, document, document. If you don't document a service, it didn't happen. If somebody asks you for medical records, show that you sent in the medical records. Keep proof that you sent in the medical records. Track that medical records requests were sent in and that you can show proof. Number 1, just don't shoot yourselves in the foot, because when it comes time to challenge what an insurance company has done, you want to be able to challenge it and not be explaining away your behavior, number 1, because that's a classic defense. Throw the accusation, shall we say, on the other side. So don't shoot yourselves in the foot. Take the time, have a compliance department, have policies and procedures in place, and document, document, document. At the same time, rule number 2 is what I would say. Just because an insurance company says these are their clinical guidelines and this is how they want something done, does not mean that's the way it needs to be done, and does not mean that that's the law. That's just what they say to you. And don't be afraid to challenge that. One of the things that I think needs to be changed, absolutely, is, number 1, this is, I'm going to get myself in trouble, but I don't understand how one group of entities can have complete control, in their opinion, over how services are provided and whether they're clinically or medically necessary or not, and at the same time absolve themselves completely of all liability for those services. And if there was one thing that I think would need to be changed, it would be that. because if those entities that, for payment purposes only, we understand, are deciding medical necessity determinations and at the same time turn around and say, but you must at all times make the appropriate clinical determinations and decisions. Well, that's great. I'd like that gig too if I could have it, because I've got all control and no risk. And that just doesn't seem the way that access to healthcare should be provided. So what I try and do on behalf of my clients is figure out, in whatever circumstance or situation there is, how can the provider, who is clinically responsible and at all times should be able to treat their patients as clinically appropriate and get paid appropriately for it, how can we try and make that happen? Again, if it's simply a matter of under reimbursement, there's a variety of things that you can do with authorizations and confirming authorizations. You just need to be able to, to take action and sue. But when it comes to denied care, I think that's a little bit different, and we need to change denied care, and we need to change lengths of stay, and we need to change who controls that. And again, the first thing that I would do is I would use maybe some of the new laws that have come out there, either the ACA or the parity laws, and I would start challenging payers with respect to their medical necessity determinations, with respect to their guidelines. Are they in fact objective, or are they just whatever they decide that they're going to be? Are they going to change them on a daily basis? They all will tell you they are all objectively based. So let's see it. Are they in compliance with parity? Is there a comparative analysis of their authorization procedures that they're using for your services as opposed to their medical services? Now, they don't have to be equal, as you know, but the authorization procedures that they are using for your services can't be any more stringent than they are on the medical side. Start asking for that information, because you are certainly entitled to it that way. Start tracking the denials. Start tracking their lengths of stay. We're talking about, and maybe Deni's going to talk about use of data or use of outcomes. I like to try and get my clients, if it is possible, to look at the denials, to look at the lengths of stay. Traditionally, the first thing out of somebody's mouth will be, that's an individualized determination. It's a medical necessity determination on an individualized basis. Is it? When you start looking at your data, and you start looking at your denials, and you start looking at your lengths of stay and your authorizations, is it individualized? Do you start to see a system? Do you start to see a pattern or a practice? That's information that you can use, because therefore it's not an individualized medical necessity determination. And I would start asking you, is there really any objective criteria for that medical necessity determination? And I'm not saying, by the way, all payers are bad and all payers are out to get providers, because as any of my clients know, I'll come down as hard on my providers as I will on the payers. But you need access to health care, and it's got to be done fairly. And, again, so I would start looking at that as well. Use what you have to your advantage. I know it's work. Take those appeals. Take those appeals and ask the right information that you are entitled to under parity now when they're denying your care. You start to see a system and a practice and a pattern. You can do something about that. Challenge the authorizations. Challenge their medical necessity criteria and guidelines. If they say they're objective and you don't know where they came from, and the denials of care based on their medical necessity determinations, and you are or otherwise, or in their pre or post payment reviews, contradict either their own guidelines or the objective guidelines that are being used, then challenge it and point it out to them and start aggregating it. There is a variety of things that you can do. The doctor last night also talked about, which I thought was, do you have a question? Go ahead. Yeah, the question in the back of the room is how, for the smaller providers, how you operationalize, some of the suggestions that I have. And, and what I can say to you, you're right. I hear the word, I'm always looking for the word, being the lawyer, in your administrative, department, what are your policies and procedures, and who's your compliance officer, and those kind of things. And people look at me like, compliance officer. But I mean, that's just a term of art. But there are certain basic things that you can do. I'm sure that although you may be small, you still have somebody who's tracking your authorizations, or a billing vendor who's tracking your authorizations, and and you need to work with them very, very carefully if you're using a third party. But you certainly are tracking, particularly if they need to be authorized, your care when it's authorized, and how many days there are. There are simple things that I think that even as you're small that you can do. If somebody requests medical records, I don't care if it's on a spreadsheet. I don't care if you have electronic. I mean, everybody, most even small providers now have had to go to EHR. So, so can you use your EHR, Kipu or whomever, whatever you may be using, in order to be able to track some of this information. But whatever way you can, and whatever basic way you can. Again, I know you're small, but I cannot emphasize enough, as important as the clinical care is, and I know that it is, and I know so much of the resources goes into that clinical care and meeting your licensure guidelines and trying to provide as much care as you can. In looking at this for the last 16, 17 years, and trying to help providers fight when it's an uphill battle to begin with, I cannot recommend strongly enough, to whatever extent you have some administrative piece in place, policies and procedures, certainly somebody who is tracking that, and documentation. I mean, I can talk to you specifically, but it's whatever that you can use as a means. Again, some people will use something electronic, some people will use paper. I don't care what it is, but you need to track both what you're doing and the information and where it's going. You just need to, because there's no way for you to fight for your entity unless you have that. Yes. Sure. Yeah. And you are absolutely correct. And when you say, oh, I'm sorry. Again, the answer is the same one that I understand completely. And the answer to the question was, again, what does a small provider do when you go through the process that I'm describing, and document, and appeal, again, knowing it's going to be to no end, because you appeal, and it generally stays the same as if you track those statistics. I'm sure you will. What do you do? And again, as a small provider, I understand that. There may not be much that you can do. You can go to your regulators. You can find a lawyer like myself, or even for somebody small on that end, may be willing to help you in that end. And quite frankly, you can hope that some of the larger providers out there, or some of the coalitions that are out there, will fight, who have a voice and who have a means to make the change. Because you're absolutely correct.
We tried to do it nationally, and we didn't have a lot of success. I've been talking to Michael Barnes a lot, well, not a lot, but a few times recently, and one of the things he suggested, there's a few of us in Florida that have been working really hard together, and Michael suggested that maybe Massachusetts and Florida should get a lot of our attention, because there's a lot of media attention, there's a lot of treatment down here. There are some laws that are on the books. We have the ear of the legislators. In Massachusetts, they have 14 days of treatment now, so they've got some momentum, let's say, up there. He suggested, rather than trying to fight this nationally, that we pick two places like Florida and Massachusetts, get together and try to make some significant changes in these two areas, that may lead us to have some more success around the country, because up to now we've been trying to shotgun this approach in different places with different organizations, with different messages, and we just don't have the money, the legal teams, and the resources that they have to fight back. You know, one of the questions I had in that respect is we've gotten a lot better at getting days. We're not quite as good as getting paid for those days. And I'm wondering if, you know, some of the tactics I see them using, and I spent my whole career in private pay until the last year. Like Dr. Barthwell said, this is kind of new to me, and it's been an eye-opening experience because I was an insurance broker and grew up in a family of insurance people, so I knew a lot about the other side. And I'm amazed at the lack of information. You know, if you call up and say, what's your usual and customary? They're not going to tell you.
Well, that's a very bad word. I would never ask that question anyway. But
Okay,
go
well,
ahead.
and it may not be that way. We work with the billers to do that, but
You never
it's
wanna
just,
take
there's
their
no
allowed
information up
amounts.
front.
You're not taking that.
They'll pre-certify, they'll say, yeah, take them in, we make an educated decision, and 6 weeks or 6 months later, we get the EOB that says, you know, we'll give you nothing, or $47 a day, or whatever, and then
If
you
you
go.
even know, because the remark code doesn't tell you a thing. That's what
Yeah.
you need to hold their feet to the fire, because they have an obligation, as some of them may have found out recently, that sending out EOBs or denials that simply say service is not as billed, or no information that allows you as a provider to meaningfully challenge their denial or their basis, which is great. But if you all do not challenge that or have the ability to challenge that, all a payer needs to do on that little remark code is say, sorry, service is not as billed, and you can call 10 times, 100 times a day, and they're not going to tell you. But you can get that information from them if you push hard enough. You've just, I agree, have to have the resources to do it. And as long as they know that you don't, it's not going to change.
No.
But again, I think people are starting to get angry enough, and it's starting to get to the attention of those who may not previously have given you all much credit. And they're starting to see that there is another side to the coin, and that maybe they need to start looking at your side first.
Yeah.
And I know
Well,
we need to
Mike-
turn that.
If you are in Florida and you're interested, come see me, because we've been having discussions about it, and you know, we need to do something. So.
But
Right,
a
Mike's
denial
gonna
that says service is
carry
not
the-
as billed is not acceptable,
Would you
ever.
take the microphone to the back, raise your hand, the fellow. Well, we still want it recorded, and we're only going to take 2 more comments before we switch to Deni. So it's either a comment or a question.
Well, you know what we're doing? I got with my lawyer, and we're going to start subpoenaing paid records. They can strike out all the confidential information. Show me what a record looks like that you say is medically necessary and something that's going to get paid. And it's somewhere to start.
Well, that's the problem with the medical necessity criteria and guidelines. Even if you're following them, apparently those reviewers are not also following them, or you're not putting the right buzzwords in there, but you have no idea what those buzzwords are. But I would say I don't know why a buzzword needs to be there, as long as it's documented appropriately that it's medically necessary. You don't need to give them their buzzwords either for it to be medically necessary. So I agree with you. So challenge that but again, you've got to get somebody to actually tell you, well, the reason is you didn't put X, Y, and Z word in your document, so we're not going to pay you for it. But you've got to get somebody on the phone who will tell you that and who will admit that. And then you challenge that, because that's not objective, and that's not what the law says, by the way.
I'm glad this has stimulated the discussion. I've got one more comment on this. We're going to hear from Deni, and then we're going to come back to open discussion. So go ahead, Brian.
To echo your, Brian Crowley is my name, I'm here in Florida. To echo your, I think the argument needs a collective response. So to echo John's statement and Mike's statement, for anybody, how many people here are in Florida that have treatment centers? Hands up. Okay, a lot of you. There's an organization called FADA, which is more associated with state contracts and whatever, but they have created an offshoot called the Florida Behavioral Health Association, and that is going to be specifically a combination of private payers and commercial provider interests. And they've been around for 35 years, and they're well respected with legislators, well respected with payers. On the state contract side, something happened 2 months ago, which would be my vision for this side of the industry. Is they get together twice a year with payers and they sit down like this, and they say, what's working, what's not working in our space, and collectively they solve the problems. The other thing is, I find, for anybody in Florida, is the least expensive way to get involved in this. One, there's 2 bills in Florida right now that are going to impact our centers.
Mm-hmm.
2 is, if you can't afford the $5,000, $10,000 a month retainer for an attorney, get together and have a collective group, put some money in. You've got to put your money in, and make a collective effort to take on a payer and have that discussion and dispute with them if you so wish. That's the only way we're going to win the race here. Is payers almost seen as the 800-pound gorilla. We're small. We've got to unite, but that's going to take a degree of trust, and I think that's what this community needs to get over in terms of we need to start working together. And what does that mean is dropping this competitive stuff and seeing the bigger picture.
I agree completely. And by the way, you can get through to the payers, and you can get through to their behavioral health departments, and you can find out what they want from you. And we can work collaboratively with them, because I don't want to leave you with the thought that we don't. Because, again, my goal is not to sue. My goal is not, honestly, to take your money. My goal is to provide access to health care, and if we can do it in a different way, we can. We just need the mechanism to be able to get to the right people to do so, and that's what's been so difficult to get done. But it can be done. But I just want to leave you, again, with one word, because I think this industry, you get so beaten down. Just because an insurance company says it so doesn't make it so. Ask questions, fight for yourselves. That's all I have to say.
So who could argue that this is not the most exciting time to be in this field? A friend of mine says it's the best of times to be addicted and get treatment. It's the best of times to be in this field. I typically say if you can take anxiety and relabel it as excitement, you'll have a very exciting life. So look, I mean, I'm just a kid in the early 80s who had spent way too much time partying at Studio 54 in my young 20s and teen years and wanted to go back to school and become an addictions counselor. Only place that would take me was Community College of Philadelphia, and that's kind of where I started. 9 years later, I was finishing my internship in Baltimore, and I worked in all different kinds of clinical care. And I had no intention to be a researcher, but you have this year where you can't get licensed because you don't have the experience. You can't get the experience because you can't get hired. You don't have a license. I thought, those guys at Penn invited me to come do a fellowship. I'll go see what those researchers are doing for a year. I say that as a way to say, the whole man plans, God laughs kind of thing. So I went there for a year, and 18 years later I left. And in that time, what happened was that I got a niche of training people to deliver care that could be evidence-based, and I went around the country initially training on the Addiction Severity Index because almost every state was mandating it back then. And everywhere I went, I heard a lot of the same things. Hey, do you have one of these that can also do ASAM? Do you have this in Spanish? Do you have one of these that helps with treatment planning? Do you have one of these, And I just started writing grants to make these things, I was not a scientist who said, hey, I have a theory and I'm going to test it. I was a clinician who said, there's a need in the field. Let me write a grant for that and see if I can get them to pay for me to develop it. And then, of course, I'll study it and I'll publish on it. So even though I'd rather stick needles in my eyes than write journal articles, that's what I did for 17 years. And so along the way, I developed a number of evidence-based practices and ways to, in my opinion, part of our job is to make it easy for counselors to do their job. Make it easy for them to deliver evidence-based practices, to document what they do, to match the treatment to the patient's specific problems. What can we do out there to make that easy? I mean, you got to go back historically. We grew out of a paraprofessional field, and this is certainly a global kind of summary, and some may disagree, but essentially, the Vietnam vets were coming back. The government said, oh my God, we don't have treatment. A bunch of them are coming back addicted. We're going to have treatment. Nobody said, well, that's okay. Their health care dollars will cover that. We said, let's start a block grant. So we started a block grant, still $1.2 billion right now. All good intentions. It did great stuff. A lot of people got treatment. But as a result, substance abuse treatment was never delivered. It was never documented, it never had to have the same credentials, and it never got paid for like healthcare. Okay. But it had a lot of great people doing a lot of great work. And it had some great people doing not great work, like anything else, right? But we were not guided by standards like healthcare is. And by the way, importantly, we weren't paid for the way healthcare is. And so that's how the field grew into, in my opinion, where we're at. Now along comes parity and healthcare reform, and we go, great, we're going to get paid like them. We're going to have this we're going to have parity like them. You can't treat diseases above the head any different than diseases below the head, la, la, la. Good stuff, very good stuff. Hasn't come into fruition, as you all know, right? But along the way, we were struggling. And estimates are that a huge percentage of treatment programs will not fully make this integration into healthcare reform for the very reasons of how they developed, right? So those 17 years, as I was responding to the field and the demands of what to do and how do we deliver evidence-based practices and studying what works, a couple of things I had the great benefit of doing was starting treatment systems in countries that had none. So back then in the early 90s into the early 2000s, there were a number of countries who said, in our country, we don't have a drug problem. Therefore, they could not have treatment, right? You can't have treatment if you don't have the problem. So over the time, and what I really saw change this was the advent of people getting AIDS from HIV drug use. And that's what changed Iraq, Iran, Egypt, to say, okay, yeah, we do need some treatment. So it was kind of interesting. I mean, I really looked at myself as going in and saying, look, I'm not going to tell you exactly the best way to do it. Just don't make the mistakes the U.S. has made in these ways. And they kind of liked that approach, right? I never thought I'd have the chance to do it here. Right? So after a number of years as a researcher, oddly enough, Phoenix House, which had 120 programs, brought me in to transition them from basically therapeutic community, one addict helping another, which there's huge value in. Trust me, I'm one of them. I've been in the recovery community for a long time. I can talk on both sides. But to transition them to evidence-based practices with healthcare records, electronic healthcare records, and I did that. And then I went to CRC and did something very similar. And then this guy with a startup said to me, hey, I'm going to start up, blah, blah, blah. Why don't you come with me? And I said, you know, I'm helping run 140 programs over here. You're a real estate mogul with like 8 buildings. What am I, you know, really? You really want me to come? I finally did come, and I got the opportunity to do something I never thought I could. Start treatment in our country from scratch based on what the science says is the most effective way to deliver care, okay? So one of the things I'll talk about is some of the things we got right so far. Now I got nothing up and running, so I'm not saying we're gonna be successful, though I'm certainly planning that. We got one thing right. We went out and we pitched and we raised $250 million from one funder. So here we are with our team, and we're developing this care. And the huge benefit of that is that we are legally going after the NIMBY folks. I can't tell you, I spent a year and a half almost being told, you know, if are you going to build a fence? What if one of them escapes and all that kind of stuff. So it's been ungodly. Personal threats, everything. But the other thing we're going to do when we open, and we know this is going to happen, that people are going to be denied care, that insurers and others are going to not work within parity. We're going to wait until we get the exact right case, and we're working at some level, talking with the Legal Action Center, which I'd highly recommend, and then we're going to put our dollars down and we're going to sue them. And we're going to make a real clear case that, look, you know, you need to go out to follow parity and the Affordable Care Act. You know, you need to be delivering care the same way that you would deliver care in any other way. In order to do that, I have to be, and my clinicians have to be, and trust me, I got to hire 1,500 clinicians, directors, docs, and nurses in the next 18 months. We are going to have to be delivering, documenting, and providing care the way healthcare does that, so that I have a leg to stand on when I say, you need to cover this. Okay. So one of the things I was brought in to do here is to kind of talk a little bit about delivering evidence-based practices, particularly like in a Phoenix House system or any other system where you don't have a lot of money. Now I know it sounds like our group has a lot of money. We don't. It's all spent already, so don't worry about that. And we're not Bloomingdale's. It's taken me a while to get this. We're not Bloomingdale's. We're Target. We're Target because we want to get a lot of people, help a lot of people stay alive, get into recovery, and live the life of their dreams like many of us in here have been able to do, all right? So evidence-based practices is where I would start. So there's a few things in this area that I think you got to do as a treatment program. Deliver evidence-based practices, and I'm sorry, by trained, credentialed staff, have electronic health records, and show your value, okay? Do outcomes. Now that's a little tough in a field, for example, where there is no agreed upon set of outcomes that we're all going to go for. And frankly, while I think abstinence and sobriety is the goal, we really do shoot ourselves in the foot when that's how we measure our value. We provide so much value to the medical community, to the incarceration, the criminal justice community. We are not a field that is very good at showing our value, and that's what we need to do. So as I look at, and I'll talk a little bit about these toolkits, when I went to Phoenix House, I said, hey, let's make this easy. And I had done 3 grants, NIH grants on developing toolkits, things that are kind of like group in a box. Now, do I think that this is high-level process therapy? That's not what it was made for. It was made so counselors in the real world out there could have something to do to deliver group when they really didn't know how to do full process groups. And so just a quick example, one of the toolkits is, and I don't sell these, so it has nothing to do with that, but one of the toolkits was relapse prevention. So it's 6 sessions. I got a grant from NIDA, and we developed 6 sessions on relapse prevention. I'll give you an example of one. So it's on drug refusal skills. And we actually hired actors in New York, and they portray characters, and a guy's walking down the street, and some guy says, hey, hey, Joe, we just got some great stuff. Do you want any? And he goes, oh, I really don't do that anymore. Hey, did you get it from Eric? Eric's always got the greatest shit. Let me sit, And we go, okay, this is a bad drug refusal skill, and then we have worksheets. We have big posters that are laminated that you write, what would you say here? What would you say there? Then we have another 5-minute video with a really good drug refusal skill, right? So you give it to 20 programs, you randomly assign half get the toolkit, half get education of what's in the toolkit, measure, and turns out the people that got the toolkit understand relapse prevention better, stayed in treatment longer, were more likely to be sober at 6 months, yada, yada, yada. Great. So now I have this package, evidence-based practice, that a treatment system could put in. Texas Christian University's got like 20 of them, the mapping-based counseling, evidence-based. But what you have to do is you go in and you train on them, and right after training, you do a content knowledge quiz. It's not going to work if they didn't get the knowledge immediately after the training. But that's really not enough. We all know that. So the next thing we added to all these toolkits was a supervision checklist. Did they implement it with fidelity? And a supervisor sits in on group, which, by the way, I've had counselors say, you can't sit in my group. Oh, yes, I can. Okay, this is not a black box. This is not magic in here. If you think you're doing magic, I'm definitely sitting in on your group now. So anyway, very clear cut. You're supposed to do Texas Christian University toolkits. You're supposed to start with a look at what they were supposed to do for homework. It's supposed to be 80% patient talking, 20% counselor. Checklist. Did that happen? Did this happen? La la. And you say they're doing it with fidelity. Now here's something that's a passion of mine. All these studies had, obviously to get an NIH grant, you got to study it and you got to show whether it works. You got to compare the 2 groups, and so you get funded for that. You get funded to contact people 2 weeks, 4 weeks, 6 weeks. You even pay them $25 at 6 months when they spend an hour on the phone with you, and that's how you get outcomes. What about in the field? What do I do in a treatment program? Because I don't care how much money you've raised. No one has money for that kind of outcomes, right? So as I sit down and I think, we're opening 8 campuses of addiction medicine between Boston and Washington. So I sit down and I think about these 8 campuses and how we're going to follow up on everybody that goes through them. And by the way, I'm a big believer in the neighborhood model. Get sober where you live and work. Stay in your continuum of care, detox, residential, IOP, PHP, outpatient, AANA, cyber cafes are built into these. These are hubs of treatment and recovery, right? So how do I follow up on them? Well, I'm an outcome study, or that's what I did for a long time. And I know, frankly, all those years in NIH, all my best friends are all the top scientists in the country. I'm getting 20 of them together. We're going to sit down. It's led by Herb Cleaver and Herb Cleaver and Chuck O'Brien. That was a slip. That's my ex-husband. So we're getting together with Chuck O'Brien and Herb Cleaver. And I just talked to Tom yesterday. He's excited about it, but declined to participate. But anyway, and we're getting 20 of the best scientists together, and then I'm tasking this advisory board. Tell me what the outcomes be. Tell me how you measure them. Tell me when. How do I do that without 18 other groups doing it at the same time? How do I do it in a way that insurers value it too? How do I do it in a way that rightly so, even this would be untrue, rightly so people will say, well, she's at Recovery Centers of America, that's just their thing, that's not about the field. So then I thought, well, why don't I have each scientist, and I have the top person in the country, Jack Henningfield for smoking cessation, I've got Rick Ross, I've got every top person in content areas I'm interested in the country on this. Why don't I have every one of them bring a treatment program? By the way, why don't I have every one of them bring a patient too? So as we sit here and we think about how can we show our effectiveness, how can we measure outcomes, and we look at all the different ways places report on their quote-unquote outcomes, how do we show the field that what we do works and that it's effective? I can teach you and I can talk to you and I can make available to you how to do a toolkit and measure fidelity and this and that. But how do we as a field agree upon how we're going to show insurers that what we do works? Now, let me tell you some of the stuff that's way above my head, which is things like, how do you go at risk for some of this? I'm very interested in that. I know nothing about it, so I can't, speak to that. But how do we develop something that says we do evidence-based practices in a legitimate way? And I can't tell you enough how important electronic health records are. And I transitioned all of Phoenix House and a couple other places over electronic health records. Remember, you come in AA sometimes, for those of you who've been around, and they say all you have to do is quit drinking, and that's it. You remember the day they tell you, oh yeah, all you have to do is quit drinking and change your whole life, right? Electronic health records is like that. It is not transitioning from paper notes to electronic notes. It is changing the way you do business for the better. And a lot of this data, how long do they stay? Who stays longer? What are the demographics of the people that drop out faster? What happens, for the people that continue care? What kind of services do you deliver? All of those should be automated through your electronic health record system. And if it's not, you got to go to them and say, I need these reports. I need this. I need management by outcomes. So I'll stop there and just see if anybody has any questions or what you would like to comment on, Andrew.
I'd like to comment on all of that, but there's not enough time. I want to start the discussion again. I have a few notes about how do you document and how do you manage when you have a small program. If we get to that, we'll get to that. If not, I'll talk to you afterwards. But comments, questions, responses. Yes, sir. Can we get the mic, please?
Can you give me a document or suggest a document that I could read or multiple documents that I could read to get educated, like maybe like a % of where you are, but in that direction? Yeah, no, you, yeah.
Yeah, I can. One of the first things I would do is go to NREP, the National Registry of Effective Programs and Practices. It's not perfect, but it is.
NREP?
Yeah, NREP, NREPP. It's part of SAMHSA's website, right? Not perfect, but that is where there is the listing of all evidence-based practices. Again, not perfect, but that's in there, and that should hold some stead for you as you say, we're doing evidence-based practices as known by NREP. But the other thing is you can contact me. I have a list of all of them and what they are and who you would use them for. I was at Phoenix House, we made about 35 toolkits. Now, I don't have the intellectual property rights to them, apparently, so I can't give them to you, actually. But I can give you what they were, a description of each, when you would use it with what, and how we did it.
Awesome,
If you
thank you.
put that together, then I'll give it to Dee to put on the
Okay.
Axis website, and it'll be available to all of you and your other colleagues who are in other rooms.
Friedman. I'm with a startup group, Sanctuary Recovery Centers. And I was just commenting on...
Eileen? Ms.
Eileen,
Parsons?
Yeah, and earlier when somebody had the misfortune of saying regular and customary to you, and you kind of blanched. But
Very bad words.
my only thought on that was that regular and customary is not something that a treatment provider would come up with. It's nothing that we ever said, thought about, dreamed about, had any idea about. We got that language in our brains because in the denial process, one of the things that was constantly told to us was, well, that charge is above our reasonable and customary for your area. And just like the gentleman alluded to, we would say, okay, well, what is the reasonable and customary? And they would hang up.
My favorite topic. You really have hit on my, one of my very favorite topics. Okay. You sell a service. You set the price for your service. This is the only, and this is really my lecture, and I apologize to everybody up front, particularly payers who are in the room. No, I did. This is the only industry, in my opinion, where I know that the buyer of the services believes that they can set the price that they're going to pay for that service. Now, if you have a contract and you've agreed in writing and you've negotiated a written contract and you've agreed to discount your charges, for access to volume access, whatever whatever you want to call it, I could give you the spiel. Okay. Other than that, as far as I know, you have a charge for your service like everybody else has a charge for their service. UCR and allowed amounts and allowed rates and all of those, you're absolutely right. They were developed by payers in terms of benefits and their contracts with their members and their benefit plans. You're not a party to that contract as far as I know. I somehow don't think that you are. And so I never discussed allowed amounts, allowed rates, accepted rates. That's, again, unless you've agreed to take that, I would never agree to take that.
Can I probe a little bit more? Because
Sure.
I want you to understand very clearly, Ms. Parsons, when you are working with someone who has not negotiated to take someone's, right, I know, it's like being called by your...
This is not legal advice. This is just my opinions out here.
Yeah,
Yes.
your opinion.
Go ahead.
If you haven't negotiated a contract, well, when you negotiate a contract, there are some things that you give up to get some things, and I've heard you talk about them in the past. So you might give up because they are identifying patients and referring them, or they're going to pay more quickly, or so what are the things that you
Sure.
might get by giving up your set rate?
Well, again, I think the providers in this room can probably talk to that better than I because they're the ones who are actually doing it. But my general understanding is if you agree to participate in a payer's network, you have access to all of those members who who are part of that health plan's network. You also have what I call predictability because you generally know what you're going to get paid and when you're going to get paid. And there's a lot of benefits in that regard, maybe not in others, into having a contract. And you might be willing to discount your charges in order for a number of those benefits. But if you're not getting any of those benefits, and as far as I, again, understand it, if you are, quote unquote, out of network with a payer, and that payer's member comes to you, that payer has also paid an additional premium to the insurance company to be able to go access an out-of-network facility or provider. That patient, as I also understand, particularly these days, cost-sharing obligations are substantially higher in doing so. So for the life of me, I cannot understand why an out-of-network provider would then get paid less than somebody who is in network. I can tell you what the payer's response can be, and so can some of the payers here, but it's real easy to me. The goal is always to pay you less than you pay the network providers because then, they want to have network providers and they want to send their members to network providers and they want you either to join their network or stop taking their members. But the idea is always to pay you less.
That piece right there was worth the cost of being here for me. I don't know if you all were paying the kind of attention I wanted you to pay to that, but just cogitate on that for just a moment. Because they're trying to de-incentivize you're taking the out-of-network member who has paid more for the privilege of seeing you and may be obligated to pay you an additional portion because they've made that decision to be seen out-of-network. And there are reasons why people would want to be seen by an out-of-network provider. There are a whole host of reasons why people want to be seen by someone of their choosing. And there are some things that you get that are accrued to you as the insured by going to an in-network provider. But if you choose to pay more to not do that, and then pay an additional fee on top of that for the privilege of having a choice, why should you be denied that? So that was worth the cost of getting here to me.
It just, again, it's the same thing. Just because an insurance says it so does not make it so. It may be that, as a matter of course, you get paid what you get paid, but that should be your decision, and there are other options to you as part of that, unless you have agreed with them about that.
My name is Tom Moricade. I am the principal for Kimberly Reed Genesis in Fort Myers. Our last speaker spoke to NIMBY and how to overcome this situation. Very briefly, we're fighting for the right to exist right now. We went through a year and a half working with zoning staff. We went to a public hearing that should have lasted 3 hours and lasted 3 days. We took all the bullets, we jumped in front of them, we thanked everyone for their comments, and at the end of that, we earned Lee County zoning staff recommendation for approval, and we earned a hearing examiner's report which showed that we proved entitlement to this rezoning in order to open our treatment center. This went to our county commissioners to be ratified, and it was voted down 5-0. The most disturbing part of it is how poorly we were treated by our commissioners, how dismissive and how rude they were to us as citizens who care deeply for people in recovery and whose lives have been altered by recovery dramatically. The opposition formed a political action committee, funded it with $100,000, and made public statements in the newspaper that this money is to go to the opponent of anyone who votes to approve this rezoning. So that's the kind of thing we're dealing with. Their goal is to drain us financially, spiritually, mentally. We're determined they will not succeed, but in that determination, what has worked in the past and what is working now to overcome this type of situation?
Yeah, thanks for that. I've been there with a lot of that, including personal death threats, and it's really, really remarkable. And I've been through that up and down the New England corridor for the past year, like I said. We have had ones, to be totally honest, we have had ones we walked away from because it just wasn't worth it. It's not public knowledge yet until right now, but we had one township paid us $2 million to walk away. Now, that sounds like a lot of money until I tell you we probably spent at least $500,000 in legal fees and down payments for the buildings and whatnot. What we did was we waited until we had the most egregious offender, until we had a place where they said, oh no, you're zoned for this. And we said, okay. And somebody said, no, you better go in front of the zoning board and just have them vote and make sure. Went in front of the zoning board, voted 5-0. We are zoned for that. Okay, great. Went to the planning commission. We don't think you're zoned for this. Went back to the zoning board. And they were stupid enough to tell us, we're going to uphold that because it's an election year and the citizens of the area have really decided they don't want this in their backyard and la. So we waited a little longer for a couple of more meetings, got knocked down at a couple more meetings there, and then now we're suing. And we're suing every member of the zoning board individually. We're suing the township. We're suing in state and federal courts. And we're doing it purposely to say, you know what? This is against the American with Disabilities Act. This is against the Fair Housing Act, and you cannot discriminate against us. But one other place, and this is one we did walk away from, wasn't as clear-cut a case, and it had been zoned forever. Actually, technically it wasn't zoned. It had an exception for zoning for 36 years as a behavioral health residential treatment program for disabled adults and kids with autism and traumatic brain injury. And they said, oh, it's technically not zoned that way, so you can't have that zoning. So apparently, it is zoned well enough for you to get treatment for behavioral health, just not our behavioral health. So we have a PR presence and team, and we have the legal representation to do this. And our hope is that, this opens it up for the field. It's, you don't just need us to get through. We need the field to be able to get through. So that is one thing. The other thing I do, I had the head of one zoning board in New England State, and they said, we want to know if you'll deny admission to anybody who has a conviction in the criminal justice system. They have a state law that denies that makes that illegal. There's a state law there that says it is illegal to deny them treatment if they have it, So I had to just sit there really nicely and say, actually, your state law, Massachusetts 432694B prohibits discriminating against people that have that. So part of it is doing your homework, and we haven't done as good a job as that. I haven't done as good a job of getting the recovery community involved and getting people who are in the field. What I have been surprised by, though, are treatment programs, particularly ones that are, that are Bloomingdale's. When I'm not going to be Bloomingdale's, I'm Target. Come out against us. Oh, we don't need more treatment here. Really? Your governor's got the new task force. People are dying in record numbers in your city, and you're going to come out against it, and you're full, and you wouldn't take the people I'm taking anyway. You're going to come out against me. Come on. The field needs all of us to survive, not just a small number of us to survive. So I would say, pick one you want and sue. Now, the reason we're not doing it with everybody is because what help am I to people who need our services if I get held up for 2-year battles in every place I'm trying to open, right? Pick the best one and go.
I've heard a lot of good things about you, and you're a surprise to me to see you today. And you went going back to rule number 1, document.
Don't shoot yourself in the foot, yes.
Well, with medical records, what do you recommend, I guess, A, legally, and then B, is at least as a best practice, sending medical records to payers?
In terms of how to send them?
Yes.
Well, it depends on whatever way that it makes sense for your program to do so, so long as you can prove they were sent. Some payers insist that you fax only, which
they're always lost.
If they want to sit there for 8 hours, right? As long as you have, but then you'll have your fax confirmation sheets. But I don't like that either, because again, when you're faxing, it's so hard for pages, to get missed, and your fax confirmation will show 25 and there were 30 there. Either if you can get an email and password protect it or encrypt it, that's great, or FedEx, again, but I password protect and encrypt your discs. I mean, it depends on your means, but that's how I always like them to be sent, as protected as possible.
What about that software the attorneys like using that is the same as mailing, would be equivalent to mailing something certified mail that holds up in court if you had to?
Software?
Isn't there a...
There's a number of different means, to do so. Again, electronically, that you can do so. So, whatever that, again, to me, you just have to prove that they were sent and that every page was sent. And again, I know for smaller companies, it's very, very difficult and expensive to keep copies of every record that you sent, because your medical records for each patient are 200-300 pages long. But to the extent that you have the ability to do that, I would do that. My question, and I thought where you were going, and it's a question that I'm seeing so much nowadays, and Deni mentioned it, with the advent of electronic health records, which were basically imposed on everybody, and it's supposed to be such a good idea. I can't tell you how many times now I am finding complaints from the payers about the use of electronic health records, and that the clinicians in their behavioral health units don't like the electronic health records because there's so much of checking the boxes, and they want to see where you're going to check your box, whatever it is, that you have entries in every single place, because they'll say, well, I don't like this electronic health record, or it's a cut and paste job, or if you're cutting and pasting, it looks like your entries are being cut in and paste. So the only thing that I'm going to give you quote unquote credit for, and those are the terminologies that they will use, is for the words that were different in the next day's entry than the one in the day before. So I'm finding that there's a lot of pushback, which I find just fascinating, to the use of the electronic health records in that regard. And so I was wondering if that's the case with you. And with the toolkits, I was thinking the same thing. if you're using these toolkits and somebody's providing a treatment modality and that's the documentation for it, and it's a yes, no, we did this, but the group progress note for that insurer's patient is not individualized, even though it's a group progress note and the start and the stop time isn't there, whatever the case may be. I'm wondering if you're, going to get any pushback.
I'm going to let her answer, but now you hit my sweet spot.
Well,
So go ahead.
I'll just give you just a quick thing. So you're mistaking what is a supervision checklist.
Okay.
When a supervisor goes in, they're actually looking
But
at what
it's
the
not. Okay.
right, and then we do a full
Okay.
progress note that ties it to the
Electronically?
treatment plan.
Okay.
With that,
Okay.
we programs have done it both ways, electronically
Okay.
and not electronically. But yeah, there's still a full progress note.
So
I'm going
there's.
to ask
oh,
one left
Okay.
field question. Are treatment centers I'm from Florida, Wellington, are newly licensed treatment centers, is Cigna accepting claims if you're newly licensed and not accepting claims?
You might want to ask Cigna, who's here in the room, but
Where is he?
No, but I don't know if you're talking about it again. I know there's an issue you're talking about when you have a provisional license versus, or you're just talking about just in general because
A Cigna pulled
that's
out.
a good question.
Yeah. I want
Yeah,
to
that's a
lift it
question.
over Florida since this is a national conference and we spent a lot of time talking about Florida issues. Let's talk about that issue, though, of documentation because it's been sort of thematic. And I like to think that as programs, talking about newly licensed programs, develop, that they have some thought about what their purpose is, what they're going to try to achieve. And I've been, sort of describing programs really of the past, not of the current and the future, that have been 12-step facilitated of a 28-day model or less as really being able to achieve, what is able to achieve for the person who is admitted is to allow that person to understand that there is this disease, that they in fact have it and how it's been expressed in them, and that a remedy for it exists. Very little beyond that actually happens. You get exposed to the remedy and then you're told to go forth and work that remedy. That is quite often the case in these kinds of programs where the staff don't have the expertise to do a process group, where they have to be given a manualized therapy because they don't have the innate ability or the training or the experience to do a process group to deal with the material that the patient or the client or the guest in that program brings forth. So that at best, if you are on a Minnesota model treatment, you recognize that this disease exists, understand how it's expressed in you, you understand that a remedy for it exists, but then you're sent forth to work the remedy. And generally being sent forth to work the remedy is going to AA and letting AA begin the life transformation. That may not work going forward in a medical model. Because if all you can get after having spent 30 days with your doctor is an understanding that you have a cardiomyopathy, then there is very little rationale for putting you in a residential program to do so. And you can't get, 4 days in a hospital after an open heart surgery. So why would you have 28 days somewhere sequestered in a quasi-medical environment to find out about a disease? Someone is going to create an expectation that we teach you about that disease before you get there. Now, if you're going to make a case that that treatment has to take place in a sequestered environment because the risk of using is so great that you're an imminent threat to yourself or others. If you're not brought in somewhere safe, that if we leave you out there and try to teach you about it while you're still out there, you might die, you can begin to create a rationale. But we're going to have to get much better in the pre-treatment and the paratreatment phase of describing how this disease, which in the past may have had a 20-year mortality associated with it, is creating an imminent risk of death, and why that is a part of the rationale for bringing them in. So we've got to start thinking about what it is that we're trying to do. Now, many of you are working with programs with a set of interventionists who say, I'm not even going to refer these people that I've done an intervention on to a program that's not going to keep them for 90 days. It certainly has become the standard with healthcare professionals. It's the standard with most other people following an intervention when it's been determined that you need a residential level of care. NIDA is on record saying you need at least 12 weeks of treatment, or why bother? Because it is in that amount of time that you can acknowledge addiction, commit to recovery, and reduce or eliminate inducements to use. But we have got to get so sophisticated in describing what it is that we do that we are communicating that in the medical record, or the environment that we're working in is going to move more toward Corey Waller's view of what we're going to have to do and less of what it is that we've been accustomed to doing. I'm not saying there's not always going to be somebody who can have an ultimate choice. They can pay cash for 90 days away at a spa-like environment. Those people will continue to exist. But if we're going to live in the healthcare system and be paid by healthcare dollars, we need to remember Deni's description about where we came from and recognize that the block grant acted as a huge safety net for the development of this system, which has only just started to evolve. And I've been describing it as the addiction treatment enterprise and addiction medicine, and we have not created a marriage of them yet. And we have wanted the addiction treatment enterprise to be paid by healthcare dollars without fully making and evolving ourselves to be deserving of it in many instances. Because if all a person is going to get is exposed to the remedy, to the knowledge that the remedy exists, and it takes you 28 days to do that, somebody's going to tell you, stop doing it there. Do it somewhere else. Do it in a different way. So, not to add more fear. Mike in the back, please.
Yeah, hi. My name's Eitan Alexander. I'm from a treatment centre organisation over in London, in England, called the UK Addiction Treatment. We're potentially looking to open up over here, and we came here to see what all the struggles are. And great, right? So, well, no, it's interesting because from what I've heard, we've come from a different aspect that, everyone's here, they'll do work and various levels of care and treatment. And what's happened in the UK is that we kind of had the same thing where the insurance money wasn't the insurance money, it was actually the government, so the local authorities, the statutory sector, and they would pay, and that there'd be this fund and everyone would go in. And what actually happened was that the government didn't feel that they were getting bang for their buck, and I guess so I'm associating the insurance money here as with the government, I guess, or tax dollars, or however that works. But the thing was that the governing body, we had a governing body over there called the Care Quality Commission, which is the same thing, I guess, as the DCF, and they manage all hospitals. And the problem was that we were falling down the crack because, they kind of class us as a care home, not as a treatment center. So we kind of like, are they able? Yeah, they come in and they can go and do their own stuff. They don't need that 24-hour medical care, right, to go and help, grandma go and eat, her soup through a straw or something. These are able-bodied people who want to get well in their therapy. And the problem was that those guidelines, what was going on, they fell through the cracks. And to be honest with the treatment centers, exposed that, and people knew what the system was, and then all of a sudden the local authority said, well, this isn't working. We're now going to impose what you need to go and do, and that's kind of where it sounds like everything's heading here. That's kind of scary, because you had these forums where, look, I'm in recovery myself, and you go to get a bunch of addicts in a room, right, trying to go and get them to agree anything, right? It's just that's not going to work. But in essence, something needs to change, as everyone's aware of that, and it's just about somebody taking the lead, because in the UK right now, the Care Quality Commission, they've just restructured everything, and my money's on that 75% of the treatment centres out there will not meet the essential standards, because now there is an essential standard, which is imposed by people who haven't got a bloody clue about what we do, and that's scary. And so you have to keep raising the bar, and so all of a sudden there's going to be a lot of centres out there that now are not getting funding, all right? Because in the UK you don't get insurance money because it doesn't cover your policy. But the thing is that it's a question of, from my experience, of what's actually happened, and everyone's talking about it. It's just somebody taking a lead. And saying, okay, this is what treatment should look like. This is what we expect, instead of it being exposed the way it was in the UK, and the money just running out and people closing down, and people like me, but we're growing off the back of that, because I'd rather make $2 rather than 10, and still helping the patient, and all this evidence based is what needed to happen, and I guess what my question is really in network and out of network. Is that the right terminology? People how many people are in network as a percentage of providers, and how many are out of network? Because I guess that's the key thing, because if it's 75% people who are in network and they're kind of following that and they're getting paid, and there's this 25% who aren't, and that's what that's all about, well, then more people need to go in network. If it's 90% out of network and 10% in, that's how I see it. I was wondering what your thoughts are on that.
I don't know the numbers.
Well, here in Florida, the vast majority are out of network, not in network. I think the vast majority would love to go in network, but they need to get paid reasonable rates to go in network. And actually, it's interesting, Andrea, because talking about, on the medical side, because I do a lot of medical work as well, and the shift from fee-for-service over to value-based payments and outcome-based payments, episodic care. I'm actually, it's interesting because there was so much overutilization of services on the medical side and healthcare delivery, and the need to get more bang for your buck, so to speak. Again, it just is incredible to me on this side because it's so underutilized, and it's still fee for service or per diem. But I would actually love, and I've done it with a couple of providers, kind of tried to move to a case rate or an episode of care. Because if you're going to be liable clinically anyway for the treatment, then let you actually be able to make the clinical determination on your own. And so I'd like to see that trend if you're talking about going in network. And I've done it in a couple of situations that there were reasons for that. But, I do think that it is certainly something to explore, and that's where you need your data. Again, that's where you need to be able to track your lengths of stays and the cost of your care, and coming up with case rates either by levels of care or by, classifications, and actually seeing if we can get something done there where, and you can have it with a case rate or an episode of care, the full treatment, and you can treat those patients individually the way they need to be treated. And if the payer on the other side, wants to have some reassurance for that, on this side as they do on the medical side, I think you can build in some outcome-based, standards in terms of the length of stay, perhaps that on average that the patients were there, how it came out, the utilization, or even some have broached, again, some recidivism rates, which I'm hesitant to in this field, but it can be done. And I think you all need to explore that. Again, it's about taking back control of the clinical care that you're providing and still getting paid for, and still having the payer on its side feel that it's getting, it's getting, quote unquote, the quality of care for the members that they are serving. And I think that's where Deni, and others who are developing some of this outcome-based medicine, that you can slowly build that in with your data. And maybe that is a way to go. In the meantime, again, we're still working through this field and arguing over, again, what the single objective standard is. I mean, I still don't understand why we can't just have a single objective, standard, of care, and not have 5 different ones and have everybody worrying about what each payer's medical necessity guidelines are and whether they're going to meet them or not. If you're going to, again, insist upon controlling medical necessity, then at least can we have one objective guideline that we all know what we're following? Can we not at least have that? So while we transition into something else?
I'm going to ask you to continue your applause and thank our speakers.